On the call, my name is John Santoro. I'm a neurologist who specializes in Down syndrome over at the Children's Hospital, Los Angeles. We run a large clinic and a research program as well. And so today we're going to talk about some of the neurologic issues that we see in persons with Down syndrome. As I mentioned, it'll be a short presentation. We're going to go over the highlight reel of the important things to know, important things to look out for. And then I'll talk about some of our very cool research opportunities as well that we have for some of our persons with Down syndrome as well. And then I'll introduce Natalie as well. Natalie's our clinical research coordinator over at our clinic. So she manages our neuroimmunology program, which encompasses our Down syndrome program as well. So with that, I'll share my screen so everybody can see and we can get started. So let me click some buttons here and let's go. I'll go all the way to the beginning. So as I mentioned, my name is Dr. Santoro. We're going to be talking about the neurologic complications of Down syndrome. So, you know, I think that the biggest focus when we think about Down syndrome, it's often about the intellectual disabilities, hypotonia, autism spectrum disorder. These are the most common things that we see in persons with Down syndrome, especially in childhood. But I think that there's actually a number of other things that sometimes get glazed over because they're relatively infrequent. And so the design of the talk today is to become knowledgeable on what some of those signs and symptoms are, so that way we can seek earlier care before anything serious might happen. So in childhood, there's the big three, so to speak, of things that we see pop up. So the first one is hypotonia. And what hypotonia is low tone. So basically kind of floppier muscles. And I think many of us have seen this in our loved ones. It's one of the major reasons that we see children with Down syndrome achieve their motor development milestones a little bit later. But it's pretty much ubiquitous, meaning that it affects almost everybody with Down syndrome. It is a major reason why we're always recommending either through the regional center or through the school districts early and aggressive therapy with physical, occupational, and speech therapy. We know that those early interventions can help and that it's not a treatable condition from the standpoint of it's not something that we can really reverse, but the therapy services that we can kind of get in place make it so that way we can get persons with Down syndrome at least as strong as possible to kind of overcome some of that hypotonia. The second important one to know about is that autism is actually present in up to 20 to 30% of people with Down syndrome as well. The unique feature of this is that it's often diagnosed much later. So when we think of people without Down syndrome who have autism, the diagnosis is usually about 2 or 3 years old. In persons with Down syndrome and autism, that diagnosis can come as late as 4 to 6 years. And so there's no specific treatment for this, but again, getting access to things like ABA therapy, either through the school district or through the regional center, can be really helpful because it unlocks a lot of resources for families and caregivers. I think that this is one of those things where we're trying to research the reason why such high rates of autism exist in persons with Down syndrome when we haven't found a clear explanation for that yet. The third one is a really important one to be able to recognize. So people with Down syndrome are at basically 10 times the risk of epilepsy over the lifespan. So epilepsy or seizures exist in about 1% of the entire world's population. So it's very, very common. But persons with Down syndrome, it's up to 10% of people with Down syndrome will have a seizure sometime in their life. The reason why infantile spasms, which are a specific type of seizure disorder, are so important to know is that they're actually very treatable, but they need to be detected early. The other thing that is unique about infantile spasms is they look different. I mean, when we think of a seizure, we think of somebody kind of locking up and having their eyes roll back in their head. Infantile spasms actually just have the arms kind of spread out very suddenly, and sometimes you'll hear a cry. Well, you'll see that cluster together. So the baby will often do that a few times in a row, and it looks like they're just being startled, but we'll see that the development will start to deteriorate because it's a seizure disorder. This is something that we always consider a medical emergency, so it's something to bring up with your pediatrician or call us over at the clinic because we would want to evaluate that very quickly. This is a very scientific slide, but I like to include it to note that there's a difference in terms of the types of receptors that are in the brain that actually predispose persons with Down syndrome to epilepsy or seizure disorders. And the one thing to note is that persons with Down syndrome actually have less of these KCC2 receptors in the brain, which help to kind of keep all of the electrical activity down. And so when you are in a state where there's extra activity, that can lead to a seizure. As children with Down syndrome get older, there's two additional things that we always want to screen for. One of them is called Atlantoaxial Instability, meaning that the top of the neck is a little bit looser because of that hypotonia that exists across the lifespan. And sometimes the bones of the spine can actually press against the spine itself. The reason why this is so important is that if you identify it early, you can prevent any type of neurologic problems. But if there's a delay, it can actually result in paralysis. And obviously, we want to try to avoid that. We used to screen for this way back in the day. So those of you with older loved ones who have Down syndrome, it used to be around 10. The pediatricians would take an X-ray of the spine, but we've found that that is not necessarily helpful in the prediction. So we're always looking at, does somebody have evidence of spinal cord compression? And the symptoms that would be associated with that would be weakness, and specifically difficulty walking, sensory changes, so all of a sudden the legs or the arms are going numb, and then difficulty or changes with bowel and bladder movement. So all of a sudden, somebody who was using the bathroom very routinely is starting to have accidents. That's another sign that things are kind of, something needs to be evaluated. The other one that we've seen and we've become a center of excellence for recently is something called Down syndrome regression disorder. So this is a potentially inflammatory disease of the brain that is manifested by people all of a sudden. So everybody, the loved one with Down syndrome is going to school, takes care of themselves, toilets independently, and then all of a sudden, they develop insomnia, they develop muscle stiffness, which is called catatonia, meaning that the muscles just don't move anymore, changes in gait, and I often say that this looks like they're walking like an old man or an old woman, aggression, hallucinations, delusions, meaning that you think that things are there when they're not, or inappropriate laughter, or changes to the mental state, meaning that they're kind of staring out the window and they're not really home. This is another condition that we would want to know about very quickly, and we've actually started to see that treating patients with immune treatments are actually the way to reverse this condition. But it gets missed a lot. A lot of the time, there is a preceding stressor, like a family member moves out or something to that extent, that may precede this. And so it often gets diagnosed improperly as depression or anxiety. And so if you're seeing any of these symptoms, we would want to know about it and potentially do a workup for that. The issue that I want to focus the most on today, though, is stroke. Believe it or not, individuals with Down syndrome are at a higher risk of stroke, up to 26 times more likely than individuals without Down syndrome. And so the symptoms of stroke, I think, are very nicely appreciated right here, where it can look like anything. It's often going to be balance, so a loss of balance, headache, or falling over, blurry vision, or the eyes are looking in different directions than they should be. Your face can have one side that's drooping, so it'll look like you can't hold water in one side if they're eating, or they can't smile the same. Arm or leg weakness, difficulty speaking, which obviously can be hard if your loved one doesn't, communicate verbally, but for those that can, we want to know that too. And then T for the B fast is always time, right? So stroke is an emergency, you want to call 911, and if your child is less than 18, you want to route them to our center so that way we can work it up and try to figure out a reason for that. Now, there are many different causes towards, for stroke in persons with Down syndrome. The one that we see that is the most common is something called Moyamoya Disease. And Moyamoya is a Japanese name, and it comes from the terminology of puff of smoke, which is what we actually see on the testing, where we see that the blood vessels have developed abnormally. And what you can see on that right-hand side over there is these big arteries that you see on the side of your neck get very, very narrow in persons with Down syndrome. And because of that, the brain actually develops these kind of fragile vessels in the brain, which can sometimes pop or cause an ischemic stroke. This is an example of that puff of smoke that you see, and that's because of that narrowing that you see right before you get into that puff over there. The diagnosis is difficult because in persons with Down syndrome, 77% have already had a stroke by the time that they come in. And when we ask families, a lot of the time, some of those symptoms are actually present beforehand. And we talk about this as a mini stroke or a transient ischemic attack, a TIA. And so if you're seeing that some of this weakness or difficulty speaking is coming on and off for no reason, that's still something we would want to get an evaluation for. When you come to the emergency room, if this was ever the case, we would get something called CT angiogram, where we look at the blood vessels. And then this is a surgical intervention at this point. So we'd have to get our pediatric neurosurgeons in to actually do a bypass over that very tight vessel in the neck. The other one that I want to talk about that's a little bit different and more on the opposite end of the age spectrum is something called cerebral amyloid angiopathy. This is caused by trisomy of chromosome 21. So we have extra amyloid precursor protein, which can accumulate in the blood vessels. And as you can see in that little circle in the middle of the screen where it says CAA or lobar bleed, basically the amyloid precursor protein deposits into those blood vessels and then actually deteriorates the lining, and it causes little bleeds to pop up. And so when you look at that little MRI over there that says A, those little dark circles are actually little pieces of blood that have leaked out from the blood vessels. This is something where we want to know about this because it can cause neurologic deficits, and the way to prevent it is to actually avoid certain types of medications, specifically blood thinners. So this is something, again, that is usually a little bit more related to older individuals because that amyloid precursor protein has to build up over a long period of time. But it is something that we are constantly searching for, especially because people can present, again, with any type of symptom associated with a stroke. One of the research studies that we're doing at CHLA is to actually use something called a transcranial Doppler ultrasound. So this, as you can kind of see in the diagram or the picture over here, is non-painful and doesn't require you to be sedated. So we can use this ultrasound probe, the same one that you would use when you're pregnant to look at the baby, against the side of the head, and we can actually look at the blood vessels. The reason why this is important is we don't have to put anyone to sleep for it. For those of you with loved ones who have had an MRI before or really had any procedure done, often we have to use a general anesthesia, which comes with risk, and it's a big deal. So the advantage of doing research with this type of probe is that this is something on a yearly basis. You could go to the pediatrician, they put the probe on for a few seconds, and they say, don't worry, you're at very low risk for Moyamoya disease. I've included our contact information. So we have a clinic that can evaluate patients with really any neurologic concerns in Down syndrome. There's the clinic number, and then my scheduler's name is Jessica Rios. She's lovely. She speaks English and Spanish. So don't hesitate to call if you have any needs on that front. And then Natalie, who's on that call, has her email right there. And then we also have a global email line that's just DS Research that goes to me and Natalie and our nurse as well to help triage if you have a more general question as well. But we're here. We're happy to answer any questions that you guys may have. I can go through other parts of the presentation as well if that would be of interest. But that's kind of the high level view of the things that we're looking for in our neurology clinic focused on persons with Down syndrome.
I have received many calls since your presentation, I think a year ago or 2 years ago, regarding regression. What are the things that they can families do if they find out that there's regression?
Yeah, so we treat regression really urgently now. I think historically we didn't know what to do with it. And so if you see that your loved one is all of a sudden not functioning like they were before, we have a very low threshold to have them evaluated. So reach out to our clinic. If you tell Jessica or Natalie that you're worried about regression, we'll try to get you in a week or two. We wanna get things done really, really quickly because there is a potential treatment for this, and when we have that, it would be silly to delay it. Go ahead, Margot, I see your hand up.
Yes.
You're on mute, can't hear you.
Yes, so I wanted to say I have a 23-year-old son who just on the 5th of August, out of the blue, very active, social, everything was going good, Down syndrome, trisomy 21. The only thing he had of health issues was sleep apnea. He had a stroke and seizures. I feel that there was many times the seizures that I was that he may have been having seizures all along. And I had been taking him to ER many, many visits in the last year. And it was undiagnosed because of the CT scan coming back normal, blood work coming back normal. Now come to find he had to actually have a stroke for us to be able to see. They talk about amyloid issue with the blood vessels. Stroke affected his left side. And so now I want to know, like, am I giving him the best treatment? What's the next step? I know they're going to do an angiogram again because they did one while he was hospitalized for a month, but they want to do it in 3 months because it was a hemorrhagic stroke. And they want to make sure that they're not missing anything because the blood was too swollen in the brain. And
yeah, and I'm sorry to hear that. I mean, you know, this is a story that we hear over and over again, is that, well, everything was normal.
yeah.
And I think that, you know, until we train more people to understand the nuances of persons with Down syndrome and how to interpret these tests, I think that this is something where we keep beating our head against the wall. And it's really hard as a doctor to hear these types of stories, because these are things where when we know that there's a 26 times more likely stroke risk in a person with Down syndrome, that should be the first thought on our mind. So, you know, at our clinic, we can evaluate patients up to 40. It's not your usual children's hospital experience. You know, I'm a trained neurologist in adult and pediatrics, so we're happy to see and help out, you know, if that would be
good. Yeah.
benefit, but it's complicated. And the biggest thing now after the stroke has occurred is, you know, exactly what your doctors are looking for, making sure this doesn't happen again.
Right. Yeah. And he continues to have he had a couple of episodes of seizures.
Yeah.
Even with the medication now. I guess they call it breakthrough of seizures. But I'm really curious about the transcranial Doppler ultrasound. You know, that's really interesting, because if we had known about that and that had been in place, you know, again, with the doctors being
here.
Yeah, that would have been great too.
Yeah, and that's what our goal is what is easy, right? Because I think that as we've all seen with our loved ones with Down syndrome, it's a complicated disease. There's a lot of moving pieces. So what is the easiest thing where if you could just put a little wand on the side of the head, that's going to make a huge difference long term. So, you know, I'll put, you know, actually, Natalie, if you could put our contact information just in the chat as well, because I realized I took down that slide. Reach out to us for anything. You know,
we're
happy to help.
Thank you.
All right, I don't have your name, but I see iPhone and a hand raised. So question.
Yeah, question. I have a question. My daughter is 23. Can you hear me?
Yes.
Okay, she's 22. I'm sorry, 22. She was fine at 20. She had 3 seizures within a 6-week period. She's on Vimpat now, 100 milligrams twice a day. She hasn't had a seizure for over 14 months. How long do I have to keep her on seizure medication? And is that good for her?
Yeah, so unfortunately, I can't give specific medical advice without, seeing a patient. In general, it depends on the cause of the epilepsy. So usually we get to a period of about 2 years, and then we start to say, is this something where we can potentially come off on it? Now, all medications, no matter what they are, come with side effects. Thankfully, Vimpat is one with a lower side effect profile, but it's something to talk about, with your doctor, because at 2 years, I always think it's reasonable to try off, because we do know that, the way that we diagnose epilepsy is what is the risk of developing further seizures, right? And so if there's, for instance, structural reason, like the brain didn't form correctly in one particular area, that's something that won't change over time. And so the risk of epilepsy on or off medications may be higher, right? But if there is no cause that was ever identified, it may be reasonable to try off. And we certainly take the approach of less is more, right?
Okay.
We want to keep people safe and protected, but what is the lowest amount of medication that we can get away with, that is going to prevent seizures, prevent anything dangerous from happening, but also, provide protection long term.
And do you know anyone in Orange County who does what you do? Because insurance wise, it's hard to go to your clinic as a 22-year-old to LA, you know?
Yeah, no, and it is hard. I think that the advantage is we can do telehealth now after I see somebody in person for the first time, which has certainly made things a lot easier. The UCI team is the most advanced, but they focus so much more on Alzheimer's disease that it's a little bit harder to get that in between care. So, I mean, you know, reach out to Jessica. She can help you navigate some of the insurance things, but I understand. I mean, now that I live a little south of the city anyway, and I know that driving into East Hollywood is a bear. It's not something that I want anyone doing unless we absolutely have to, but you know, we're happy to work out. Or if you have a local neurologist that you've been working with, I'm happy to chat with them over the phone as well in kind of a less official capacity, if that's helpful.
We have
All
some questions in the chat. I don't know if we can take a look at
I'll
that
read
as
some
well.
chat questions. I see Cynthia, you have your hand up. Let me answer some of these quickly. Does your clinic offer support for adults with regression? Yes, we can go up to 40. After that, we're probably starting to route out to some of our other clinics locally. Next question was, for DS regression, do all symptoms need to be present to diagnose? No, even if you have one of those symptoms, that's enough for me to really say like you should come in. I will say a lot of families miss some of the symptoms, like for instance, catatonia. It's because a doctor should be the one diagnosing that, not a family. So I think if you have a concern, we're concerned. Come in and see us. Marisol asks, is there a connection between epilepsy and Down syndrome? Absolutely. So individuals with Down syndrome are at a 10 times the risk, roughly, risk of epilepsy. That's because some of the receptors are different in the brain of persons with Down syndrome, and they are at a higher likelihood for excessive epileptic discharges. So we see it bimodally. We see epilepsy early in life, and we see epilepsy later in life. So, you know, those are two factors, but they're related to trisomy of chromosome 21. Somebody asked, what are the usual diagnostics that have to be done for somebody with regression disorder? So we take a very broad approach. So we talk about the Holy Trinity. So we get an MRI, we get a EEG or an electroencephalogram. It's non-painful. We just look at the brain activity. And then the third one is something called a lumbar puncture or a spinal tap. Same thing as epidurals. When you're pregnant, instead of putting fluid in, we're taking fluid out. And the reason why we have to do that is that the brain is protected from the blood by a barrier. And so we have to go past that barrier to see what is going on in the brain. It's by far the most helpful test that we've done, but we don't do it all on the same day. We come in for an evaluation, make sure all of the tests are actually needed, or if there's another explanation for the regression as well. Patty asked, is CHLA the only site for the transcranial screening? Yes, we're the only site for right now. If our research goes really well, my hope would be that we can expand that to other clinics across the country and at least across the West Coast, because I think that it's going to be a game changer for how we can diagnose things without having to do invasive testing or sedation testing. And then Jamie asks, what screening do you recommend for the seizure disorder in DS? The number one thing that you want to do for anyone who has seizures is you want to get an EEG that tells you what type of epilepsy is going to be present. And most often patients who have epilepsy will also get an MRI to make sure that there's not a structural reason for that seizure. And that both of those are designed to help decide on the best treatments. And Cynthia, let me take your question because I think we're almost to the end of all the other ones.
Hi. Okay. So my son is 16 years old and he's had regression through like 2 major regressions, and he's diagnosed with autism as well. So I'm assuming it's all autism, but I kept wondering, like, what if I'm missing something? Like, what are...
How old was he when he had his regression?
So I think he had it around...
Recording in progress.
I'm sorry, I couldn't hear you. Muted out on that one.
Okay, sorry. So so initially he had a regression when he was like 2 or 3 years old, like where I feel like he forgot everything and it was like starting from scratch, like he would just stare blank. And then he had a couple years later, he did another regression where he was like closer to being potty trained, and then just overall, and then I was just like, oh, it's happening again. But like by then he was already like, I had already been told like, oh, he's probably dual diagnosed. So I was just like, okay, so he has autism. So this is just another regression regarding autism. And the reason I question it, like, what if I'm missing something, is that he was also under chemotherapy, and he got ALL when he was 9 years old. And through some stages in chemo, it's like they opened the door to an Elias where he was communicating, he was being more verbal, like more attention. It's just like, and I kept telling the doctors, I was just like, it's just like he's Elias without the autism. I kept on telling, but like people wouldn't get me. And I was just like, even my brother started noticing, and just a couple family members. And so I started thinking, like, what if we're missing something? Like, this isn't probably autism, and it's probably something that could be helped with medication. So
and Cynthia, you're hitting it on the head. I think a lot of individuals out there with regression have been diagnosed with autism, and it kind of fits, right? If you look at all the symptoms, right, like it does make a lot of sense. But think about, what happens with chemotherapy. It's immune suppressive medicines. And when all of a sudden you're seeing that somebody is responding to that, people should look sick and look worse on chemotherapy, right? We all have loved ones who have gone through some type of treatment for cancer. So to us, we start to see a lot of this. And this is something where when we first started evaluating patients, with regression, we didn't know what to expect. So we started to go very broad, but then we kept getting this same signal over and over again. There's inflammation, inflammation, inflammation. So if you're seeing that pattern, I mean, that may be the sign that something was different. Now, could he have autism and regression and have them be independent of each other? Potentially, right? And I think we're still trying to learn, what is the best way to approach this. But if I don't know, mom radar, dad radar, if those things are going off, I usually just say reach out to your doctor. That's something that is a little too specific to be something that is just a nebulous diagnosis like autism.
So you think I should look into it to see if there's something else? Because like, I don't know how to go about it. Like, I just kept telling his doctors and his people on his team, like, every time he would go through like a specific, it wasn't generally all of chemo, but like certain stages, it was like, he was different. He was alert. It was just so much more. And so I kept thinking maybe getting him on some type of medication of what would help him. Yeah. So I just
reach out to us. We're happy to help with that, because clearly there's something that doesn't add up, right? I mean, that's the thing, is if you told me what should a person on chemotherapy look like, I'd say tired, sleepy, not wanting to engage, maybe a little bit depressed. So if you're seeing the exact opposite, then we have to do a little bit more deep digging.
Okay, thank you.
So Jamie had a question. What is the treatment for regression? It's not a one size fits all. It depends on what the most likely etiologies are. It depends on some of the symptoms that are present. So it's variable. The big four that we use are benzodiazepines for people with catatonia. We do use antidepressants, not because I think that this is depression, but it helps stimulate language regaining of milestones. For people who have more delusions, hallucinations, aggressions, we sometimes will use antipsychotic medications. Again, not because I think somebody has schizophrenia, but because that's the treatment for some of those symptoms. And the only disease modifying therapy that we've found so far is immune treatments. And that's with something called IVIG, or intravenous immunoglobulin. Let's see, another question. I have a 26-year-old son who has an X-ray showing he didn't have Atlantoaxial instability. Now he does martial arts. Is there a way that the stable joint suddenly becomes unstable, and how can we know this before it happens? The short answer is by 26, everything should be, basically calcified enough to keep everything in place, but there are exceptions to the rule. There's not a lot that you can do for pre-screening. We found that the X-rays are not highly predictive, so always just watch for the symptoms. Something like Atlantoaxial instability won't happen overnight. It's going to be kind of more slow, but if you see that there's a gait disturbance, changes in bowel or bladder movements, weakness, all of that sort of stuff, that's the low threshold to go straight to get evaluated. And even telling your doctor, I want to be evaluated for Atlantoaxial instability, is totally okay. You're not going to make anyone angry with that one, because that's a known risk in persons with Down syndrome. Let's see. Jamie also said, is Atlantoaxial instability need to be inflection and extension. Yes, it should be, but again, like it's not a highly predictive test. So we've become as a medical community a little bit more agnostic on it, but it doesn't mean that it's not potentially helpful as well. Patty asks, is it too late to try immunotherapy if it has been treated for depression and anxiety for 6 years? So the magic number on regression seems to be 3 years. If we get you before that, we can actually make a change with our immune treatments. However, we just had a patient maybe 2 weeks ago from out of state who came in with basically a decade of symptoms, and we've still found that there's inflammation, and we'll be starting immunotherapy. So the chance that we find inflammation is lower, but it's still, potentially treatable as well. And I generally take the approach of the immune treatments that we're using are relatively safe, all things considered. So, we have a pretty low threshold to give a trial of medication and see if it helps. And then if it doesn't, we can at least say, we gave it a shot. Rose asks, my brother is now 26 and started with what now I feel like is regression since age 12. He used to bounce back, but the pandemic made it so hard, still struggling. Is ever too late? I mean, the short answer is, I don't know what too late is. We don't know as a medical community. So I take the approach of let's see if there is something reversible, because I tend to be the person who doesn't want to go down without a fight. So, if you're coming to see me, it's usually a reason to do the extra workup. So I'd say, Rose, it's never too late, but we have to be cognizant that the chance of the recovery goes down a little bit. Patty asks, have you ever used stimulators like the V-Light? I have not. That's not really a scientifically validated intervention at this point, but it's something where I've heard about it. I don't know if it's necessarily produced a lot in terms of therapeutic effect right now, but we don't have really good studies to show anything about that one right now. I know that's kind of a non-answer, but it's the best I can do with that.
Dr. Santoro, I have a quick question before you go to Mary. I think it's Mary next, but what happens when the seizures go untreated?
Yeah, so seizures that go untreated can be dangerous for two reasons. One of them is called SUDEP, which is sudden unexplained death associated with seizure activity. We don't want that to happen, obviously, but you always want to treat seizures. The other thing that not treating seizures can cause is more seizures. So remember, the seizure can damage the brain tissue if they go on long enough or there's enough of them in the course of a day. And so what can happen is now you have one little spot that was causing seizures, and if you don't treat them, now you have 2 or 3 different spots that are causing seizures. So we always want to nip it in the bud, as early as possible, both from a safety perspective and from the standpoint of not making the epilepsy worse. Great questions, though.
I have a family that didn't treat it, and this person is an adult now, and but they went to their country because they were so desperate. They told them not to give them any medication and just let them sleep for 14 hours a day. Is that a real treatment? No, that's one of the worst pieces of advice I've ever heard given. So if it's the problem is if you don't treat seizures, you can get something called epileptic encephalopathy, meaning that the brain actually starts to slow down. And so people will sleep 20 hours a day because that's the only way to prevent themselves from seizing, but it's not a long-term solution. And it's actually quite dangerous to do that. Now, like I said, every medication comes with side effects. But what we do is we try to tailor the different medicines towards the patient. And it's something where, again, the risk of not treating the epilepsy and causing brain damage from that standpoint or causing death is so much greater than the potential risks of the side effects of the different treatments. So working with your doctor to find the right therapy that's going to be low side effect, good for the loved one is a really important thing. And if you're getting advice to not treat anything, this is like a 1950s approach to medicine in persons with Down syndrome. And it comes from the days where we used to put people with Down syndrome in institutions. They didn't even stay home with you. It was this out of sight, out of mind, don't treat any medical problems. And that's not the way we need to
treat persons with Down syndrome. If we treat a lot of these medical problems, people with Down syndrome live totally normal lives, right? There's still a risk of Alzheimer's at the very end, but there's a risk of Alzheimer's with many people. But I think that it's something where we have to get out of that mindset of just don't worry about it, because this is what was going on with regression, right? Regression was reported in 1946, and we didn't do anything with it for 80 years until recently. So it's just an example of a lot of these things we need to diagnose and we need to treat early. But finding the right treatment for the right person is a big piece of this, because me sitting in a clinic and just recommending a bunch of different therapies, if you're as a family member not on board, that's an important factor, right? Like we need to work together to get the treatments that are going to help the most. I see Margot had a question that I missed. My son had been treated for hearing voices, unknown if this is accurate or if it's a mental health symptom of brain changes. Seizure could be the RX caused by the stroke. Yeah, I mean, a lot of these things, it depends on where the injury to the brain is in a person with stroke. But yeah, there are mental health issues in persons with Down syndrome, depression, anxiety, a lot of these things will pop up, but we take the approach just like we do in psychiatry for young persons with psychiatric symptoms. We do a really broad workup to make sure that that's the diagnosis, right? So I think of psychiatric diagnoses in persons with Down syndrome as a diagnosis of exclusion, meaning I need to rule out all of the other medical problems that are reversible and then leave that psychiatric diagnosis as the only possibility remaining, because I don't have a test for psychiatric disease, right? And to just start a patient on these medicines is kind of willy-nilly and something that can be dangerous, right? Again, like putting somebody on a psychiatric medication long-term without knowing if that's the right thing, I think is just as risky as the medication itself. You guys have some pretty good questions today. So any other
Can I ask a question now? I've been waiting.
Oh yeah, sorry, I can't see who has the hand up. I apologize.
Okay, so we have a son, 20 years old, and he has been diagnosed with sleep apnea for a couple of years, but we haven't done the CPAP on him because number one is it's not that serious, and number two is we know that he's not going to be able to wear the CPAP overnight because he's pretty moving around. So my question is whether without CPAP, with the diagnosis with sleep apnea, would that have a risk of stroke? Since or had a stroke, yeah, mainly because of the brain.
Yeah, so it's a little, so when we think of the risk of stroke with persons who have just sleep apnea, no Down syndrome, it's typically going to be much later in life because the blood pressure starts to go up and it can cause some damage to the blood vessels. Much less common a cause of stroke in persons with Down syndrome, but the CPAP is a real challenge because it's not easy to get on. People don't want to wear it. And if you have a mild sleep apnea, sometimes we're like, well, is it even worth it? We would recommend trying still, because when you improve the oxygenation to the brain overnight, that can actually help with reduction of the microarousal. So even though you don't see it, or like we don't see it, his brain is waking up multiple times as a response to the low oxygen that can occur from the sleep apnea. And so many people with sleep apnea, have, sleep apnea is very common in persons with Down syndrome. Almost everybody has it. But if you can try to practice, and we always recommend practicing when they're awake, so have it become part of their routine. But for some patients, it's not been feasible. And there is a surgical intervention right now called a Inspire device, where they actually implant a stimulator that helps keep the tongue forward, so that way they're breathing more at night. It is approved in persons with Down syndrome who are adults. So it's another option if there's absolutely no way that you can get the CPAP on. So it's still important. Is it going to cause a stroke in and of itself? Probably not, but definitely something to try to find a solution to if you can.
Oh, I have another question regarding the transcranial Doppler. Is that supposed to be a routine assessment, or just when you have symptoms, you go for it?
My goal would actually to make this be a routine assessment. So when you come for your annual health visit once a year, we put the probe up and we say, okay, you're good until next year. Right now, we don't do it anywhere. We don't even do it if you're having a stroke. So my goal is if we can even catch one person out of 100 who's going to have a stroke. That's still really meaningful, but we have to do the research to prove that it's necessary. So that way we can get things like the insurance companies to pay for it. We can get it into the doctor's offices. So it's a long haul, but that's what we're doing the research for, because we want to make it a standard of care type of treatment or type of test.
So right now, this is not something that insurance will cover.
Correct.
If we come to get one.
Yeah. Yeah,
Got it.
and exactly, and it's expensive enough to be prohibitive, which is why we're doing the research.
So can a patient, can a person with Down syndrome just join your research to do that?
Absolutely. So our study right now is for persons aged 8 to 26 years. So a pretty broad age range, but just email us on the research line and we can get you guys up for a visit. It's very straightforward.
Okay, great. Thank you so much.
Yeah.
And we have also Carol. Carol wants to ask a question. We have 2 more people, I guess, and then we can.
Hi,
Carol?
can you, yes, hi, can you guys hear me?
Yes.
Okay, awesome. Thanks for doing these. These are super helpful. Okay, I don't even know where to start. I have an 18-year-old Brandon who has a dual diagnosis, also Down syndrome, autism. He's had a couple of what seemed to possibly be seizures. One was like 1.5 years ago and one was recent. But he had an EEG, but only for like 30 minutes. It wasn't super long and it didn't show anything. And then we're scheduled to have one that they do overnight in November. But that's all he's had done. It's been questionable as to whether or not they've been actual seizures. So just wondering, does that sound appropriate? And then the other question was regarding catatonia. We tried Abilify for him. He can be very impulsive and aggressive at times. And we saw when we started with the Abilify, it really seemed to be have some great results. But then he kind of just went nuts at one point after about a month being on it and increasing to 5 milligrams. He stopped sleeping for like 2 nights and was very aggressive and appeared to me very catatonic, not responsive. We went off of it. And then the strange thing, the doctor we're seeing is a neurologist at Chalk. And so he's thinking that he wasn't metabolizing the Abilify appropriately or enough. But he was just, after we went off of it, took a little bit for that kind of non-responsiveness to resolve. And then he's been kind of better than ever. So I don't know if he still has some of that in his system, or anyways, the catatonia, what just kind of scared me when you mentioned that. And I wanted to mention, does that make sense to only be related to Abilify, or could there be something else going on?
That's a little odd. Usually Abilify is not going to cause catatonia, but so is kind of the general course of that. So we see that SSRI type of compounds in persons with Down syndrome, they have this hyperactive response. So often we'll see more aggression, tics, we'll see a lot of excessive behaviors that we don't see normally, unless there's something that's being targeted specifically. But I would say like the combination of seizure and catatonia is an odd combination. The EEG, like the ambulatory EEG, the one that you go home with overnight, that's designed to see if they can capture a seizure, which is always very, very helpful, especially when you don't know if a particular event is one or not. But catatonia is never normal. So that would be something you want to either bring up with the doctor or come up and visit us.
Okay, and he's going to have the EEG where we have to go into the hospital and stay there.
So he'll do the 3-day EEG.
Well, we're going like at 9 a.m. and then spend the night till the next day.
Okay, yeah, and so usually they're just doing that to see if they can capture an event. That's very, very common.
Okay, thank you so much.
Of course. Abigail.
Yes, I have a questions about like my kids. I have 2 kids with Down syndrome. My kids, they're very young. My child is 11 years old. The other one is 7. They had a sleep apnea. They removed the tonsils and adenoid gland. But then one of them, I was looking the record, the other one for the 7-year-old. She has hypoventilation, something like that. But don't the sleep apnea results once they remove the tonsils and adenoid? I wonder if the other parents had their children remove the, the tonsils and adenoid glands, because my kids have, sleep apnea, and
Yeah.
I don't know totally. I don't know. I'm still questioning that, because they do the sleep study, before the surgery to see they have a sleep apnea, and they say, okay, he has sleep apnea. Then they schedule, to remove the tonsils and adenoid glands. And then after that, they do another sleep study to see if it resolved. But my daddy hasn't done, so I have to ask for another one. But I just wondering, because all these parents say their kids have a sleep apnea. I wonder if they have their tonsils removed, adenoid, or it doesn't resolve.
Yeah. So the tonsillectomy and adenoidectomy is super common. A lot of kids get that one done because a lot of kids have sleep apnea with Down syndrome. They'll usually do a test afterwards to see how much it helped. And in about, I mean, this is a ballpark number, but about half of patients, it helps a little bit, but the sleep apnea is still there. And that's where, like with the other parent who was talking about sleep apnea, CPAP is kind of where they go after that. But not everybody will have a cure from the tonsillectomy and adenoidectomy. It's still important because it helps open the airway and it prevents really bad sleep apnea. But there are some patients that still have that procedure done and then need the CPAP afterwards too.
But how would I know what is good ventilation?
Yeah, so that's what they determine on the next. So when you do the sleep study the second time, that's where they say, like, all right, here's your apnea hypopnea index. So here's how many times your child stops breathing. And then they look at the ventilation as well. And so they combine all of that to say this combination or this risk factor means that you either have to use CPAP or you don't have to use CPAP. But they look at all of that with the sleep study.
Okay, and I have another question. This is like, I don't know if this is related, because, with the coronavirus, there were people were like, okay, get vaccinated. I have heard a lot that even though the media says, oh, they're good and safe and effective, actually that's not true. But they say that, like the vaccine that cause, blood clots, and then blood clots might be, they cause seizures. I'm concerned about that. I'm like, my kids have been vaccinated, but with the coronavirus vaccine, I didn't trust that one. So I said, no, we're not gonna get that one. But, it's too new for us to get it. And I don't want to be a guinea pig. I don't want my children to be guinea pigs. I'm just concerned about the blood clots, seizures, and all that, because I heard also other studies that, people have died of something else. And like last year or 2 years ago, everybody died of coronavirus, no cancer, no heart attacks, nothing, everything, everybody, like everything went down. So I'm just concerned with vaccines and blood clots and seizure, for my future, for my child, because my child is 11 years old.
And what was it? Black glass?
No, blood clots, the blood clots.
Blood clot. Okay. Now I got you.
No, because they say blood clots, seizures, and vaccines, because when you get the vaccine, you get blood clots, and then now seizure. So I'm just connection with that.
Yeah. So we've spent a lot of time looking at this, because outside of seeing persons with Down syndrome, my other practice is neuroimmunology, where we have a lot of people who are on immune suppressant medications or have defective or dysregulated immune systems. We've actually found that the best vaccine that we've recommended is the Pfizer version. The reason for that is the Pfizer vaccine is a little bit less immunogenic, which is important because persons with Down syndrome still have dysregulated immune systems, and it seems to be very well tolerated. The J&J vaccine is the one that, or the Johnson & Johnson vaccine is the one that has been associated with blood clots. And so for persons who are more immobile or are obese, which encompasses a good portion of our Down syndrome population, that's not the best one and not one that we've generally recommended. We have seen no significant changes in our seizure frequency, in our blood clot frequency for any of our persons with Down syndrome who have been vaccinated. But I will say this with a big asterisk, is that our population of persons with Down syndrome have such a high rate of lung disease and heart disease that the risk of getting COVID has been much higher in persons with Down syndrome. And unfortunately, we learned that the hard way when we had a lot of people in our hospital who spent months on respirators and things like that because they were more susceptible to these types of things. So it's all a personal decision at the end of the day, and I can't tell you one way or the other, but I think having a talk with your primary doctor or your immunologist, if you have one, about what's right and what may be the best way to test it is the best way to do it. I think that what we've looked at more recently is, does everybody need a boost? And the way that we've been looking at that is we test to actually see what the antibody level is. And if it's still high, we haven't been recommending boosting, because there is a concept in immunology called B cell exhaustion, where basically we drive the cells that produce antibodies so far over the edge that they stop producing all of the antibodies, right? So this is a real personal decision, and it's a decision you need to have with your individual doctor who knows your children the best. But we understand it. I mean, there's, right, with any medicine, just like we've said on these calls, there's always a risk of side effects, and same thing with vaccines. And that's a discussion that, you know, needs to be more than a blanket recommendation, especially given how complex a person with Down syndrome is. I hope that answers your question, Evan.
Yes, thank you.
We have our last question from Marcel Santiago.
Hi, doctor. So my question is, can you hear me?
Yep.
Yeah, okay.
Yes.
So my son at 3 months, I'm sorry, no, at 6 months old, he had infantile spasms. Took him to UCLA. He was treated with steroids, and that was it. Never had him before. About a month and a half ago, he had his first seizure. Took him to emergency. Now, he had challenging behaviors because prior to that, we were having ABA for him to go get blood work, get immunization, and he did great. Wow, this was very dramatic. So long story short, they had to put him under, they gave him 3 shots, try to put him under to get a CT, blood work, urine, everything. Came back with a CT, everything looked fine. So we took him to the neurologist, and they're going to be doing a EEG at the end of the month at Holy Cross. My question is, Stephen does well through routine and through ABA therapy, but I'm really concerned that doing an EEG, he's not going to cooperate. I'm wondering, is there any techniques that I could do at home that would prepare him for it? You know, I did ask, can they sedate him? And the answer was no, because they need him to be alert. Otherwise, it wouldn't be a good EEG. So I asked them if they would do an MRI. They said that depends on the EEG. Oh, he is on medication. He's on Keppra, 500 milligrams, and he hasn't had a seizure since then, since the first one. So he's still on the medication. He's going to school. The neurologist said he can go to school. He could do everything except swimming. Mm-hmm. So I guess my question is, I'm just wondering, is there any techniques or anything that we can prepare him for the EEG? You know, he had one when he was 6 months old at UCLA, but he was a baby. And
yeah. How old is he now?
He's 18.
18. So the best way that we found it is to really practice it and watch a video on it. So if you just Google YouTube videos and you show him that it's not going to hurt, that's like the change of the environment, and all of a sudden having somebody putting on something, if it's not expected, that's often been the most challenging. You can call he's going to have it done, you said at which hospital?
It's a Holy Cross Hospital in Mission Hills.
Okay.
You know, when I talked to them, and I did tell him that he had special needs, he's basically nonverbal. He communicates through a community. It didn't seem like they had a lot of experience working with adults.
Yeah, and this becomes the problem, right? Like, you know, at a children's hospital where we're so used to dealing with persons who have limited, you know, expressive language or intellectual disability, we just have a team ready to go for that. Okay. You can give it a shot. I mean, if it's clearly not going well, just let us know. We run EEGs 24/7 over at CHLA. We can get the care team in for that too, because the last thing we want to do is give them PTSD from going in for a surprise EEG. And a lot of the times at adult hospitals, the routine is you just tell your patient to sit back and they do it, right? It's like going to the barber, but it's not something that is the same with a person with Down syndrome. So, I mean, prep him as much as you can, but if you have any difficulties, we can certainly arrange that too.
Yeah, because also, because he's 18, they had said, well, he's an adult. And I explained to them that we are in the process of having do a conservatorship. And they said, okay, we'll allow one person, so that my husband's gonna go in there. But I'm just really concerned because we're trying to get answers, where the seizures came from.
Yep.
And so I'm just wondering if it doesn't work at Holy Cross, I'm wondering if we should just make an appointment at Children's Hospital.
Yeah, and that's our goal. I mean, we don't, when I started out, we didn't expect to see patients up to 40, but we do that because there's not anyone else in the community. So we have a special agreement worked out with the hospital system where we can try to help out in these unique cases.
Oh, perfect. Okay, thank you so much, doctor. I appreciate it.
Of course.
Thank you so much, Dr. Santoro, for your time. And it's come to the, unless there's another question that has to be answered right now, but in the chat, but pretty much we come to the end of our presentation. Thank you everyone for spending your Saturday morning with us. Very appreciate it. And we'll announce the next Saturday seminar. And Dr. Santoro's team will be at our next walk, which will be taking place November 13th at Santa Anita Racetrack at 11 a.m. I'm sorry. In case you want to see his team there, they will be at our next walk. Okay, thank you so much, and thank you for everything. We'll let somebody answer in the chat if you guys are able to, and then I will sign off. And we can probably stop the recording now if you don't mind. Thank you so much.